So without further ado, I'm going to ask Phil Willis just to say a few words, which he's very kindly agreed to do, to say why he thinks the nursing associate role was so important to create, and his views on it more generally. So welcome very much, Phil, and over to you.
Well, thank you very much indeed, Jill, and a particular thanks to you, Jess, for organising this. I realise how difficult these Zoom conferences are. I'm actually in the middle of another conference at the moment in South Africa, so I'm literally in and out with you. But they're the great advantages of Zoom. But thanks to everybody who's joined this morning, and may I first of all say thank you to Ian Kessler and the whole team at King's for doing this piece of research. I think one of the great criticisms I have had over many, many years is that ours as a field, the nursing field, is one where we don't take research seriously enough, not just simply the research into new techniques, but also into the way in which we're actually working, and to review the way we're working in a much more sort of objective way. And I think King's has done a superb job. So thanks to you, and thanks to NIHR for actually funding the research. I thought in particular, this piece of research was useful in that it was looking at the deployment of early phase nursing associates. And I think that's important to do, because I think there remain many misconceptions about the role. And for those of us who are very sort of committed to this particular role, this bridging role, then I'm delighted when we're having constant iterations on what is, I think, going to be an important development. I do suspect that if you'd have carried out this piece of research now, and you'd looked at the deployment of nursing associates on the first and early second phase of the pandemic, you would have actually seen a very, very different picture. Because the reports that I'm getting in a separate piece of research that I'm doing is that the way in which nursing associates have been viewed during the pandemic has actually changed hearts and minds of some of them, the most severe critics during that particular period. But perhaps that's something for later. Now, I found the report, and particularly the case studies, absolutely fascinating. I thought they were very, very useful and very, very thorough. But the bit that I was a little surprised at, and not surprised at, was the chief nurse survey. In fact, I found it surprisingly encouraging, because the biggest critics when I was doing the research and doing the initial work was from senior nurses, from chief nurses. And I thought that a really excellent piece of work that you've included in the report, which looks at the views of a range of chief nurses, really sums up the position, but also sums up just what needs to be done to convince many people of the value of the nursing associate concept. However, this is a seminar, this is a webinar, and I think we need to be a little bit controversial rather than just simply take things at face value. And I want to say that one of my concerns coming out of your research is that the exact same pattern of how we utilize professional, highly qualified, highly motivated colleagues, and how we make use of a complex and multifaceted workforce is in danger of happening again. Now, I do accept that change in any area is always a challenge. It is, and I just watching the latest episode from The Crown last night, I realized how change was difficult for even Mrs. Thatcher in those early days. That's if you believe what The Crown is about. But our healthcare staff system, and that's the whole of our care staff, and from medics, you know, right up the chain as far as healthcare assistants, our healthcare system is built up of a layer after layer of silos, with role after role being the optimum demarcation barrier, not professional competence. And when I wrote the report, I had three major objectives in mind. One was to pick up from Sir Robert Francis's work and to professionalise the higher order skills of a deregulated health support workforce. I wanted to, in fact, go further than that and, in fact, include a skills profile of all healthcare staff so that we started to semi-professionalise everything which healthcare support staff do. Secondly, I wanted to release the newly and graduate registered nursing workforce to work to their potential. And we have to remember we were one of the last countries to actually go to an all-graduate nursing profession. That was the UK, which is basically the founder of the nursing profession. We were the last to move in that particular direction. And despite the huge criticisms there were of that move, my major criticism was that we were not actually using our graduate workforce for what they were there designed to do. That was to work at a much higher level than had been the case previously. And my third objective was to recognise that today's highly complex healthcare landscape, with rapid changes to demographics, to the epidemiology, to technology, all those landscapes need a more flexible, interchangeable and interdependent workforce. Yet a very strong theme which comes through your report is, and I quote myself, "Please tell us what is the precise role you want the registered nursing associate to play in our organisations, and we'll try and fit it into an existing structure." And that comes out very strongly in the report, I think. This despite the fact that both the nursing associate and the registered nurse have just undergone the most significant review and restructuring of their professional standards, which have deliberately moved the emphasis to professional expectations away from narrow skill requirements. And there's a fundamental change in the new nursing registered nurse standards, which again has been reflected in the nursing associate standards, which actually paints a different picture. Of course, this is not universally so. Like yourselves, I have met hundreds of nursing associates, and I'm sure there are many in the room today, who have entered the most dynamic of healthcare settings, and they're now working in roles that they had thought not remotely possible just a couple of years ago when they began their training. Others have been inspired to become registered nurses and are now in a pathway. I found in a survey when I started my work that 1 in 3 healthcare assistants, senior healthcare assistants, wanted to be registered nurses. Roughly half of all nursing associates are now wanting to move on to that pathway, and many of them have that. Quite frankly, I celebrate that. I think that's one of the huge achievements of this piece of work, and not bemoan their loss as a more easily definable role. The nursing associate will change. It will go through many iterations. The new standards are designed specifically to allow for change, for innovation, and yes, to challenge our institutions. So please, let us not feel that because we have concerns about the necessary skills to take on roles, say, within mental health, that this is somehow a flaw. It's not. Rather, it's a challenge and an opportunity for the future. So my final word is to let us celebrate the fact that
it's an Ian Kessler one
of qualified, regulated and professional colleagues are joining the healthcare workforce. Let's encourage them to succeed, but let's encourage our institutions to use all our healthcare staff to their potential. And that, to me, would be the real success of this innovation. Thank you very much and enjoy the rest of your conference.
Great. Thank you, Phil. That was a really interesting kickoff, and we will let you fly back to South Africa, so to speak, and hope that things are going very well there. We'll be in touch, and I know everybody around the Zoom would like to give you a congratulatory clap for coming to talk to us and setting us on so well on this webinar. But we do acknowledge that you need to go, so thank you very much for attending this small bit. I'm going to turn now to my colleague Ian Kessler, and there are some chats taking part as well. I hope everybody's familiar with how to use the chat room. If you're not, go down to the bottom of your screen and you'll see a little thing saying chat, press on that, and you'll be able to see what people are saying. And some people like to keep it open as well. So without further ado, and I'm going to be turning to my colleague Ian to start presenting our findings here, with the reminder that the slides will be made available to you following this seminar, and also we'll be putting them up as a recording later on. So if your colleagues would like to take part, that would be a way of encouraging them to do so. So Ian Kessler, it's probably well known to many people. He's a professor at King's College London and Deputy Director of the NIHR Policy Research Unit in Health and Social Care Workforce. And this is the body that has funded this present evaluation. So over to you, Ian.
Thank you very much, Jill, and thank you to everybody who's joined us today. And thank you also to Lord Willis for a very interesting introduction. So I'm going to basically set out the initial findings from our research. It's quite a dense presentation, I'm afraid, but you'll have to soldier through it. As Jill said, this is a project that has been undertaken through the Health and Social Care Workforce Research Unit, funded by the National Institute of Healthcare Research, and we do, if I can. We do have to put a disclaimer that the material that we're going to be presenting today is our own work and doesn't represent the views of the Department of Health. So that's just a quick disclaimer. In terms of the purpose of today's webinar, where there are a number of underlying reasons we felt it was timely to hold such an event. Firstly, this is the first real occasion, I suppose, where we've publicised through an event the research that's being undertaken through the unit on the nursing associate. So we're keen to bring this material and these findings to your attention, and the project more generally. Secondly, as implied, we do, I suppose, quintessentially want to present the initial findings from the research to you this morning. And also, thirdly, to talk about the future of this project, where we will be going with it going forward. But also, it's very important for us to get some feedback from you on what we're finding, getting some insight into your own experiences, and in sharing your feedback, others also may find what's going on in your organisations of interest. So those are the five main purposes, if you like, of today's session. Firstly, then, just a little bit of background into the project itself that we're undertaking through the unit. And I'll just give a little bit of context, a sense of the focus of the work and the methods that we're adopting. Much of this is familiar to you, certainly on context, but nonetheless. In terms of context, clearly the nursing associate role is relatively recent, with the first TNAs being recruited in early 2017. The role can be placed against the context of a number of important junctures in the development of the nursing workforce, starting with the introduction of the SENs in the Second World War, mid-40s. Then as we had Project 2000, and the SAN began to wither away a little bit. We had the emergence of, as Lord Willis said, a graduate nursing profession and the emergence of the healthcare assistant. And then more recently, in the early 2000s, we had the development of the assistant practitioner role, which is also a Band 4 role requiring a level 5 qualification. So the NA role emerged against the backdrop of those in three important junctures in the development of the nursing workforce. In terms of scale, and I'm sure you're all familiar with this, and as I've already hinted at, the first TNAs were recruited in 2000, a cohort of 1,000 at the beginning of the year, followed by another fast follower cohort of 1,000. And then we've had subsequent cohorts in 2018 of 5,000, and in 2019, 7,500. So we're talking around 14 or 15,000 TNAs and NAs in circulation. And I think the current figure is about 3,000 NAs have actually registered. So that's the scale of the workforce we're talking about. And as I already hinted at, this is, and I'm sure you're all familiar, a Band 4 role requiring a level 5 qualification. But crucially, of course, this is a registered role, which distinguishes it from the assistant practitioner. I think it would be fair, however, to say, emerging from our early findings, which, as Lord Willis said, concentrated on the first 2 cohorts, that trusts and other healthcare providers have taken up the NA role a bit like a pig in a poke, and I don't mean that pejoratively, but for those of you unfamiliar with the notion of a pig in a poke, I'm sure most of you know what a pig in a poke. A pig in a poke, according to a dictionary definition, is something that you buy or accept without first knowing or finding out if it's any good. And I think there has been an element of taking up the nursing associate role, certainly in the early stages, without a full appreciation about what that role might look like and how it might be developed, which is very interesting and exciting for researchers, because it's interesting to explore how that role then unfolds and develops within organization. Now, partly the NA role has been a pig in a poke because it was introduced at quite considerable speed, but also it is perhaps inevitable that any new role takes a while to settle down. I mean, this is a map that we came up with just to see the range of organizations who have a stake in the development of the nursing associate role. And looking at that diagram is enough to give you a headache in its own right. So it is a complex landscape. And as Jill said, there's quite a few acronyms there which might need unpacking. But that gives you a sense of how complex a landscape this is for the NA role and for organizations seeking to introduce it. It's also the case that, putting on an academic-y type hat, that any type of new role, particularly in healthcare, takes some time to what one might call institutionalize, which is become fully established in an organization. And this is a framework that we have used in looking at new roles, which suggests the different stages in which a new role may develop. So starting with traditional roles and ways of working, there's clearly an initial jump towards isolated examples of the new role and ways of working, which would be the NA. And this is really a kind of acknowledgement that this role is around and available for use. We then get a move from isolated examples of the new role to the new role becoming more legitimized, which is in a way the role becoming accepted. And then finally, there's the final stage, which is the hope for new ways of working, or the new role become taken for granted, which is really the assimilation role. And fortunately, that allows us to come up with 3 A's of acknowledge, accept, and assimilate. And for organizations, and I'm not going to go through this in detail, there are clearly a number of micro processes which underpin all 3 stages, which you can reflect on when you get the overheads. But those are the 3 stages that any new role would typically have to go through. It's also the case that with any new role, there's an issue about what is intended, what is unintended when it comes to the strategic implementation of a new role. So typically we think of intended strategies leading to realized strategies. But with a new role, there's a considerable degree of uncertainty, and one might argue there's a lot of emergent strategy emerging as organizations get to grips with the role and see how it fits in to their nursing workforce. Now, I'm not going to use those 2 frameworks systematically, but I will briefly return to them at the end. In terms of our focus, as Lord Willis said, our main focus was on the 2017 cohorts, the 2,000 TNAs that started in early 2017 and qualified at the beginning of 2019, with a particular focus on their deployment. I suppose unpacking our 3 main research questions, they have been: why are NAs being introduced by health and social care providers? Secondly, how and with what effect are they being introduced? And finally, we wanted to introduce an element of contingency agency, and sensitivity to various factors. So to what extent was the role, its introduction, moderated or affected by context? For example, the types of trust, the type of health and social care provider, community, acute, mental health, learning disability, social care, and to what extent was the introduction impact of the role moderated by different stakeholder perspectives, the NAs themselves, registered nurses, nurse managers, and service users, patients and carers. So those were our three core questions. In terms of our methods, and this is the data, these are the data sources I'm going to draw upon in the presentation. We undertook a literature review. We then undertook around about 40 expert interviews with national and regional stakeholders with an interest in the role, policymakers and practitioners at those levels. We then, as Lord Willis intimated, carried out a survey of chief nurses. We got about just over 100 responses back. Around about 50 of those were from organisations which had introduced the nursing associate role in when we did the survey, which was about 18 months ago. And it's those 50 respondents from trusts and organisations with NAs that I'm going to mainly be referring to in presenting the survey data findings. And then finally, we have undertaken a number of cases. Two of those have been completed at Cambridgeshire and Peterborough Foundation Trust and at Livewell in the Southwest. These are both health and social care trusts delivering integrated health and social care services. It was obviously the case that we couldn't complete the three cases as scheduled. We were going to look at two further acute trusts and one mental health care trust. We weren't able to do that because of the pandemic. And as a consequence, it has to be said, our qualitative findings are focused heavily on community service trusts rather than acute trusts. But clearly, the survey covers a whole range of different types of trust. These are the two case trusts that we covered. Many thanks to both trusts for participating and giving us their permission to publish the findings. Cambridge and Peterborough Foundation Trust provides health and social care services. You can see for a population of around 900,000 with 4,000 staff. In early 2017, it took on 12 TNAs, 10 completed the program, 7 are actually in the process of undertaking a bridging program to become registered nurses. So 3 are in post as NAs. Livewell is a social enterprise, a community interest company, providing a similar range of services, integrated health and social care. Population-wise, slightly smaller catchment area with 3,000 staff. And it took on 2 cohorts of TNAs in 2017. In the first wave, you can see there 11 TNAs all completing, 5 qualifying and moving into NA posts. And then in September, a further 24 with 19 completing, 6 progressing to nurse training, but 15 in post. So that meant that during our study, there were 20 qualified NAs in post in Livewell. I'm not going to tell those case study stories in a kind of holistic way. The reports which I refer to in a second will tell you those stories, but I will be drawing upon data from those 2 cases in a kind of selective way. Now, the findings, as I've already hinted at and Lord Willis hinted at, are published in 3 reports. One is an interim report which covers the survey and expert data, and then the 2 case study reports which are available on the unit website. What I'm going to do in terms of presenting the findings now is connect to those core questions about why organisations were introducing and are introducing the NA role. Secondly, how they're doing it in terms of their approach, but also looking at the how question by how they're deploying their qualified NAs. And then finally, looking at that question of impact and the kind of benefits that are emerging associated with the role. So those are the 4 issues I'm going to consider drawing selectively on the different data sources that we have, the interviews, expert interviews, the survey and the case material. Why was the role introduced? Well, this is a kind of policy perspective. I mean, it is quite clear that when you talk to policymakers at national and regional level, that the NA role is seen as distinctive. Lord Willis was hinting at it a little bit when he talked about or implied that the role was perceived as being able to contribute to a more generic form of care delivery, a people or a person-centered form of care delivery, which was reflected in the training that NAs received. And as I'm sure you're all aware, the fact that their placements were in different healthcare settings, and that was designed to develop this kind of generic new type of role. Secondly, and a number of people that we interviewed stressed this as a distinctive feature of the role, particularly relative to the SEN role, that it was a role which allowed those performing it, the NAs, to progress in career terms. There was a sense that maybe the SEN role was a bit of a career dead end, but the NA role was explicitly conceived as an opportunity to progress further. And as I've already hinted at, and as you know better than anybody, this is a registered role in contrast to the assistant practitioner role, which again made it distinctive as a nursing role. Influential documents, I won't go through these, but there were a number of influential documents that provided the backdrop to introduction of the role. Lord Willis mentioned the nursing standards, which were introduced in the first set of standards at the end of October 2018. Obviously, this is important, not least in relation to the 2017 waves of TNAs who were obviously taking their training before those standards are being developed and having the programs quality assured by HEE. So that is an important backdrop to the first two waves. In terms of the objectives, these are the objectives which have already been hinted at by Lord Willis that come through from our expert interviews and from the policy reviews we've undertook. In terms of upstream, I suppose most explicitly, and Lord Willis mentioned the term, this was conceived in Raising the Bar, Lord Willis's report, as a bridging role between the healthcare assistant and the registered nurse. And as such, the implication was and is that the role is of value in its own right as this kind of bridge between the unregistered and the registered workforce. Secondly, again hinted at by Lord Willis, the role was seen as a way of allowing registered nurses to work to the limits of their capabilities and their scope of practice by taking on certain tasks from the registered nurse. This freed up the registered nurse to work at the extremes of their scope of practice. And thirdly, again, Lord Willis hinted at this, it was a role which allowed career development and formed part of a career pathway. Both an opportunity for healthcare assistants to have a new role to move into, and as a stepping stone for those in the NA role to then move on to registered nursing roles. And clearly there were a number of midstream objectives, if you like, around widening participation, because this is a role that was accessible to healthcare assistants who had often had very few career development opportunities in the past. It was an opportunity maybe to redesign services, to recruit new types of people into the NHS and into social care, attracted by the new career opportunities available, an opportunity to retain staff, partly HCAs who now had a career development pathway, and possibly also registered nurses who, having some of the pressures taken off them from the new NA role, may have been less stressed at work and more likely to stay, and also as a consequence, more motivated. And clearly the end goal, that most significant downstream consequence of all of this, was to improve service quality and outcomes through new forms of care delivery. So those were the roles, the objectives which emerged from our expert interviews and from many of the policy documents. Apologies for this fairly noisy slide, but it shows the findings from our directors of nurses survey, where we asked them to rank or state the importance of that full range of objectives. So we're trying to get a sense of the balance between those objectives amongst healthcare providers. They were asked to answer that along a scale of no importance to considerable importance. And we can see from that, I've highlighted the navy blue bar, which is the considerable importance. You can see that most of those objectives are important to some degree. The navy blue and the purple bar are fairly significant for all of those. So clearly the NA role is achieving in any given organisation a number of different objectives, but it's striking that growing your own registered nurses scores highest in terms of considerable importance, around about 3/4. Also freeing up registered nurses, that allowing nurses to work to the upper end of their scope of practice, but also providing career opportunities for HCAs. Clearly, a question like that does invite people to tick the box importance on all of them. So just to get our respondents to concentrate a little and prioritize, we did ask what the 3 most important objectives were. And again, grow your own registered nurses comes out as the most important. The aim that was ranked the most important, almost half said that was the most important one, followed by the freeing up registered nurses. So it's quite clear that career pathways, both for HCAs, but particularly into registered nursing, was a very important objective underpinning the introduction of HCA of the NA role. And I'm not going to go through these because it will be a bit laborious. Okay. In terms then of the how are trusts going about this? Well, there are 3 issues I briefly want to cover. One is about the role of partnerships. Secondly, some mention of the numbers involved and more particularly the distribution of NAs and TNAs across the workforce. Dealing firstly then with partnerships. I think organisational readiness emerged as a particularly important backdrop to the introduction of the role. This was a quote from the survey from somebody, and it struck me as very interesting. This was a director of nursing who in the survey said, we really focused on previous evaluations around the introduction of new roles, so advanced practice. And one of the themes that came out from the early evaluations was the lack of organisational readiness for the new role. So we really focused on organisation readiness, so things like awareness, visits to teams, clarity of role, expectations, that type of thing. So I think in terms of approach, organisational readiness emerged as a very important issue. In terms of partnership, it was particularly striking that the TNA initiative in 2017 was launched around the notion of partnerships, organisations getting together to introduce cohorts of TNAs. And these partnerships emerged as crucial, as I'm sure many of you will be aware. An example of systems level working, some of these partnerships mapped onto the SDPs and IACSs, others constituted subsets of the SDP, but this was clearly an opportunity for systems working. Somebody in this survey noted that partnership working within an SDP footprint was one of the first workforce things where you saw a tangible SDP type of approach. The NA initiative, the first tangible example of effective SDP working. There were practicalities around partnerships in terms of procurement, of training, the organisation of placements, which was clearly very important. Crucially, this partnership basis encouraged the view that maybe the nursing associate could and should be a system resource rather than a resource tied to a particular trust or organisation. So partnerships encouraging the view that NAs were a system rather than an organisational resource, which may link to a broader agenda going forward on the integration of health and social care. And again, slightly fussy table, I'm afraid, but this just shows you the approaches of LiveWell and CPS, who both appointed leads who played a crucial role in this first phase, a clinical education lead for nursing associates at Cambridgeshire and Peterborough, placement development facilitator at Livewell, the emergence of what was called a community of practice in Devon around the NA role, and a subset of trusts and organisations in Cambridgeshire and Peterborough. And you can see that in both of these cases, there was an attempt to align different features of the programme, so common job descriptions, a partnership-wide handbook, a Devonshire-wide handbook, shared uniforms are designed to generate some sense of shared identity, and obviously the sharing of placement opportunities. So this attempt in both our cases to align the development of TNAs as a way of developing the TNA and NA as a system resource. In terms of numbers, I'm not going to say, I'll come on to numbers in a minute. I just do want to say a brief word in terms of numbers relative to the assistant practitioner role, because we'll all appreciate that certainly in the early phases, there was some disquiet, not least amongst, and understandably amongst the assistant practitioners themselves about the NA role. A number of interesting questions emerged, which I'm not going to delve into, but are worth parking. It appears there's an issue about whether, having previously gone with assistant practitioner roles, that some trusts were actually better prepared to take up and develop the NA role. It may be that trusts who have experiences of new roles may be better able to take them on, not least in relation to that point about organisational readiness. There were other examples of trusts who had already built up their band for nurse workforce through the assistant practitioner role and were therefore perhaps a little less keen or saw less need to take on the NA role. There's clearly a debate about the relationship between the AP and the NA role and the extent to which they are complementary, and clearly the AP role extends beyond nursing to a whole range of other professions, and many trusts clearly see the two roles as complementary, although some don't. Some have shut down their AP training and are now focusing on the NA role. And there's also an interesting issue, maybe linked to the first one, which is whether there are innovative trusts. So it is interesting that trusts who went heavily with the AP role, for example, in the Northwest, are now also going heavily with the NA role. So there may be trusts who just are well prepared and keen to innovate on new roles. In terms of distribution, this is data from our survey where we asked our 50 or so trusts who had TNAs or NAs in place what clinical settings they were to be found. And here you can see the distribution. Not surprisingly, there's a concentration on general medical and general surgical wards, where you can see that round about 60%, close to 2/3 had an NA or TNA there. But they were also scattered across other clinical settings in A&E. It's interesting that over 1/3 had NAs and community teams as well, and mental inpatient wards. I did do a survey of assistant practitioners. It was as a survey of AP leads, just to provide a contrast with the clinical settings that APs were to be found. And you can see that APs tend to be, again, not unexpectedly found in a slightly wider range of clinical settings. And this is probably a better graph to illustrate that. So this is my AP survey, which I did a few years ago, and the NA survey. And you can see that NAs are more likely to be found in general medical and surgery wards than APs. But again, not unsurprisingly, APs are to be found in those other services which require AHPs like physiotherapy, OT, radiotherapy, and so on. In terms of distribution, there's an interesting issue to consider around whether trusts and organisations take a top-down or a bottom-up approach to the introduction of the TNA and NA role. In our two case study trusts, it's interesting to compare and contrast. So At Livewell, the first cohort of TNAs, the early 2017 cohort, was concentrated exclusively on district nursing teams, quite a strategic top-down approach to have one TNA stroke NA in each of those 5 district nursing teams, North, South, East, West. I think that's South Ham. However, the second cohort later in 2017 was much more of a bottom-up approach, whereby NAs and TNAs were introduced across a range of care settings. You can see 8 very different care settings there, ranging from acute inpatient mental health wards to even health visiting, liaison psychiatry. So a slight shift of approach in Livewell. And we can see that in Cambridge and Peterborough, again, it was very much a kind of bottom-up approach where TNAs were introduced into a range of different care settings, crisis team, crisis home resolution team, to inpatient wards. And I think in these 2 trusts, and I think the impression one gets is that the bottom-up approach tended to predominate in these early phases. It was a question of HCAs who were keen to progress their roles or their careers, pressing and pushing their nurse managers for this program. It was a question of ward managers individually be very keen to take this role on, rather than a kind of top-down strategic approach to where we need this role and how we might explicitly use it. Moving then to the deployment of NAs, and 3 issues: challenges, scope of practice, and skill mix. And there's a picture of people playing chess as an example of deployment. Challenges. We asked our nursing directors to highlight the main challenges. I mean, clearly these are not insurmountable barriers. These are just challenges to be addressed more or less successfully. It's interesting that finding a distinctive role, again, we asked how important these challenges were. Finding a distinctive role for the NA was important as a challenge. Also, interestingly, gaining acceptance from registered nurses was a challenge as well. Again, we did ask our directors of nurses to highlight the top 3 challenges. Actually, I'm just going to make it is also interesting that these are the most important ones. These are the most important challenges. So finding ways of integrating NAs into established ways of working was the main one. It's interesting that a third of our directors of nurses, 31.9%, still found that ensuring that registered nurses were prepared to delegate to NAs was one of their 3 most important ones. That green bar is their 3rd most important one. So it wasn't a high-ranking challenge, but it remained a challenge. In terms of looking at how the role has developed in terms of the NA scope of practice, and this is probably the trickiest area, and I think Lord Willis is hinting at that, because the standards of proficiency are broadly drawn, and there is considerable scope for health and social care employees to develop the role as they see fit, and as relates to their own circumstances and needs. One way I found it useful to explore the scope of practice of NAs was to look at the extent to which the activities and roles of NAs, RNs, and HCAs overlapped or remained distinctive. So clearly that middle space, number 1, is where HCAs, NAs, RNs all do a particular activity. They can all do it. They all do it. There are tasks which tend to be mainly the responsibility of HCAs. Where it gets interesting is number 3, where there are tasks, I think that should be which the NAs do and which others don't. There are tasks which the RN does and others don't. And I know we can debate about the extent to which is the case. And I think one of the interesting questions is, what can an NA do but not an HCA, and what can an RN do but not an NA? And I think that's where we begin to see what the scope of practice of the NA is. And I know I've heard a number of presentations that people don't like to unpack the role of the NA by particular tasks. It's more around a general configuration of activities. But I think exploring in detail the tasks that NAs do and which HCAs and RNs do, things do boil down to that sometimes at the end of the day. And again, this is a noisy slide which you can reflect on at leisure when you get the overheads. But this was me or us trying to unpack the kind of tasks that NAs did but were not being or could not be done by HCAs, and the kind of tasks which still remained the preserve of the registered nurse, where the NA could not cross that particular boundary. Now, what is interesting is this is a kind of composite list, but what is interesting is there remains huge debate around what NAs can and can't do, for example, around IVs, IV drugs, around whether in a community context, NAs can do the first visit when they go to somebody's home. And again, this reflects the fact that we concentrated on health and social care community services. In the inpatient mental health wards that I looked at, Livewell and particularly Cambridgeshire and Peterborough, there were specific examples of uncertainty as to whether the NA could perform certain tasks. So around PRN medication, which people will know is medication on request, particularly in mental health inpatient wards, section 17 leave, which is where there's an issue about whether NAs can sign off a request from a patient to leave the ward for a short period of time. Can they do that? There's also the question of night shift responsibilities, where there may be 2 registered staff on a night shift, one of which is the NA, and when the registered nurse goes off for a break, whether the registered NA can be left in charge of the ward. So in the trusts I was looking at, in particular Cambridge and Peterborough on this front, there remain some uncertainties around whether the NA could perform those 3 tasks. Now, just a few points on scope and the issues that were emerging. Firstly, it appears that the scope of practice of NAs, as I've already hinted at, evolves. It was initially highly uncertain and it evolves over time. I'll just give you one of these quotes from an NA who said, "I was in the first cohort and it was a case of we'll figure it out as we go along. We'll find out where you fit in." Again, the most frequent question from an NA saying the most frequent question I got asked for a long time is, what can you do, or can you do that? So the role evolves. Secondly, in these early waves, there was quite a soft landing because the qualified NAs and the TNAs came from the teams in which they went on to work as a TNA. So they were known and they were trusted in that team. As that NA states, the team that know you and have known you for years and years. It would be very different if it was just someone that had come in and didn't have a lot of experience. So there was a soft landing because TNAs were known by the team. Registration did appear to impact. This is anecdotal, but it's a quote from an NA who said, "Having the registration has definitely improved my practice. I thought I was doing everything possible I should and could, but actually it's 100% improved it because I have to be more accountable, more aware of the decisions I'm making. I have to actually know why I'm doing it." So here was an NA saying that registration had made a profound difference to the way in which we practice, making more aware and appreciative of her accountability. At the same time, I won't read this quote, it's quite a long one, there's still an issue of judgment. A lot of discussion about what the NA role involved and could do revolved around the term complexity, the complexity of the case, the complexity of the case of the patient. The implication being that less complex cases the NA could deal with more complex cases remained the remit of the registered nurse, raising the question of judgments around complexity with implications for what the NA would actually do. Moving on to skill mix, this seemed to be very much a work in progress. This is data from the survey, which shows that many of our respondents were still reviewing skill mix and its impact upon the trust. Around about half, 44%, were in the process of reviewing skill mix. We have to remember that the number of NAs remains small and limited to certain wards and teams. So in terms of this broader impact on skill mix, it was still a work in progress. So arguably, it was too early when we did our research. Things may have changed for these kind of systematic skill mix reviews to take place. This is a survey respondent saying the first cohort of NAs qualified in April 2019. It's too soon to measure impact on skill mix, although this is still an integral component of the evaluation process. I think there's an interesting issue about how the NA is included in the unregistered registered numbers. In a very crude way, one only has 3 options, although I know that trusts have developed more refined options. An NA can replace an HCA on establishment levels, which obviously has staff cost implications. An NA can reduce a registered nurse, which also has staff cost implications. Or the NA can be an additional member of the establishment, which means it's an added staff costs. There's an issue about to what extent trusts are going down those different routes. Yeah, that's the question of how they fit into the establishment. What is interesting, what is interesting is the way in which NAs in one of our case study trusts were used in terms of how they were counted in the numbers. So I can't find my top heavy. No, I can't find it. Yes, there it is. We did, in this particular case, found the NA was a little bit like a piggy in the middle, in the sense that what they did on shift depended on whether they counted in the registered or unregistered numbers. So this was an example of an NA, a qualified NA, who found themselves on some shifts counted in the registered numbers and some shifts counted in the unregistered numbers. And this was obviously not, the NA themselves was slightly upset by this and took quite a hard line actually on how they approached the shift. So you can see this quote from the NA saying, if I come on to a shift that's very top heavy in terms of registered numbers, as the band 4 member of staff, you do get pushed out into the HCA numbers. I'm very boundaried. If that's what I'm working as today, then there's X, Y, and Z that I'm not going to be doing on this shift because it's too much, and you end up doing two roles. So I think that is an interesting issue about how the NA is used on shift and how their role may be sensitive to the balance between registered and unregistered numbers. Right, you'll be pleased to hear this is my going on to the final part then of the benefits of the role, which in a way is the holy grail of the NA role, isn't it? About whether it has positive outcomes, variously defined. Number of throat clearing points to make. Firstly, we do have quite a significant body of research on the relationship between skill mix and different clinical outcomes. I would just point out that this is quantitative research. Often it comes from the US, which has a very different regulatory model. It often uses a very limited range of clinical outcomes, particularly mortality. It's heavily under-theorized in terms of trying to explain how skill mix relates to clinical outcomes. And one has to say that it hasn't really, despite quite a few studies on skill mix and clinical outcomes, it still doesn't seem to have been very effective in influencing debates on safe staffing levels. So I haven't seen any link between this research and any safe staffing guidance. Our research, certainly our case study research, is qualitative, but my view is that a narrative and naturalistic approach to exploring the impact of the role is quite a fruitful one, not least because, as I make the point there, NAs are found in very different clinical settings, so it's often difficult to find standardized metrics by which to assess the impact of the NA role. And even if one could, it's quite difficult to control the range of factors which contribute to clinical outcomes. Having said that, this is a work in practice, and I know from talking to people at trust level that a number of organisations are seeking to measure the impact of the NA role at ward level. One trust I know in the Southwest I spoke to the other week has developed test wards around certain metrics, around infection control, falls and various other measures to look at the impact of the NA role. But obviously there are challenges to measuring impact. I would say that, however, that when we measure impact, one has got to be clear and relate back to the objectives that we're trying to be achieved. The NA role as a stepping stone, well, it does appear both in our case study trusts and our survey that the NA role is being used as a stepping stone, both for HCAs and for NAs into registered nursing. Is it being used as a bridging role? I think there is a tension here, which if Lord Willis says we need, it's valuable to be controversial or contentious, I think there is a tension here that maybe NAs are moving too quickly on into the NA role, which is not allowing the role to embed, and now some trusts are seeking to require NAs to stay in post for at least a year or so before moving on. I think the role is being used in ways which help the NA to support HCAs. So this is a quote from NA talking about how they supported a band 3 in her assessments. The role is, we have examples of the role freeing up registered nurses. There, the NA is able to free up then that band 4 time. So maybe go and spend half of the morning with a complex end-of-life patient, and a band 4 can obviously go and visit a patient who maybe has a new wound, and also allowing the RN sometimes to spend a little bit more time with patients. I've done lunchtime meds, and the band 6 nurse was able to sit down, the NA did the meds, the band 6 nurse was able to sit down and spend one-to-one time with the patients, and it's like, when would you normally get the time to do that as a band 6 nurse? And there are examples, particularly from my cases, where the role or the NA role seems to be contributing to the delivery of this generic form of care. This is a quote: they're providing the systems approach, the NAs, they're breaking down boundaries in a way I think probably beyond what we expected. You have an established RMN, registered mental health nurse, workforce confident in the field of mental health. So bringing in NAs who have that breadth of knowledge and confidence in working with physical health problems as well. So there are examples of the NA role breaking down boundaries, encouraging more generic forms of healthcare delivery. Okay, so those are the findings. Inevitably just a taster of the richer, more complex, readable findings in the report. In terms of where we're going in the future, this is the third and final part of my presentation. We are in the process of starting up repeat expert interviews. We carried out about 40 of those, as I said. We want to go back, not least in the wake or in the context of COVID, to see how views of the role have changed. We are going to be conducting before Christmas a follow-up survey of nursing directors, and want to extend that to human resource directors as well. So we will be sending that survey out, and we're working with a number of stakeholders, particularly Health Education England, to develop this survey. A number of things we're keen to pursue. Lord Willis mentioned how COVID may have affected both the perception of and the use of NAs. We really want to go into social care and look how the role is being taken up there, and we're working quite closely with Devon County Council, who have a cohort currently of TNAs and another one planned. So we want to work with Devon and explore the role in social care. We probably want to extend, not only to look at qualified, but also TNAs, but also look at TNAs and how the role is unfolding. External recruitment, as I say, a lot of emphasis upon recruiting people, HCAs in organisations. What happens when you go to external recruitment? We want to do a survey of NAs, and we hope to get that off the ground. Explore an extent to which we can assess impact more systematically. And I think the whole issue of NAs as a systems resource is an interesting one, not least in terms of how the NA role has impacted more generally on the structure of the nursing workforce. This is a quote from a strategy document from an ICS that I saw on NAs, and I was struck when in that statement it said that focusing on the nursing associate role in isolation is not helpful. It fails to maximise the contribution the role can make to safety, quality and efficiency. It stifles flexibility and creative thinking in terms of deployment. And the implication was that the NA role needed to be considered in the context of the whole nursing workforce and how that is structured. So that's basically it. That's a summary of what I've done. I've been through the project, its findings and the future. I mean, if there are any kind of summative comments or lasting impressions, I think trusts and organisations are at different stages in terms of where they are in introducing their role, whether it's being acknowledged, accepted and assimilated. I think in general, if I was to kind of put a finger in the air and see where we were, I think most trusts that I've spoken to are around about this accept stage. They've moved beyond seeing the NA as a rather exotic role found in particular pockets. They are moving towards getting a broad acceptance of the role, but there are still uncertainties that exist which need to be dealt with before we move to full assimilation. And I'd also say, what is interesting is the importance of emergent strategies. So a lot of organisations were initially uncertain about the role and therefore couldn't develop a very sharp and refined intended strategy. And their strategies around this role and the broader nursing workforce are emerging as they become more familiar with the NA role, as they become more appreciative of what it can and it cannot do. That's all, folks. Jill?
Great. Thank you so much, Ian. We've got now time for comment and questions. Everybody apart from Ian has probably been having a look on the chat. So I'm going to ask Ian to close his slides down. As I've said, people will get the slides and will get the recording, or at least the link to the recording so it doesn't crash your email. And the slides will come out shortly, and then we've got to do some fiddling around with the recording, and you'll get that later on. So I've been looking at the chat, which has been very lively, and we will look at the chat in more detail as a research team. I'm going to try and focus on some of the points that have arisen there. There's been quite a lot around initials, and so we're just establishing that T is trainee and NA or RNA is the nursing associate. But I wanted first to see whether anybody who is a nursing associate, before turning to some of the other commentators, might like to just say a word, or even more than a word, say something. I think we've heard a lot about nursing associates. It'd be really great to hear from somebody. That's asking a lot, I know, but if anybody would like to demute and just to say that they are a nursing associate and how this appears to them, this presentation, that would be really great. But I don't want to put people on the spot unnecessarily. So I'll give them a couple of seconds for somebody to volunteer. If not, am I seeing somebody wave? Was that a wave or just a wiggle? I think maybe it was a wiggle from somebody. If anybody would like to say something, if not now, perhaps later. But there were two themes coming up in some of the questions. The first, I think we can probably say, and was picked up in Ian's final comment, was about social care, and we will be working on social care both in Devon and in some other places. The second theme that has come through from people like Peter Griffiths and other people adding to a chorus of questions about that was what are the who and what are the nursing associates freeing up people from? Is it registered nurses? Is it healthcare assistants? And what are they freeing them up to do? And then we've got another question coming in about the change in the apprenticeship registered nurse role. But I'm going to ask Ian to focus on the first question, which is, what are the nurses, as nursing associates, freeing up registered nurses to do? And I think we had a glimpse of that in some of the quotes, but maybe something more general to say around that subject.
Yeah, I mean, this is probably, well, this is a hugely informed audience. So there may be people in this audience who have a stronger feel for what NAs are freeing nurses up to do than anybody. I mean, I think it's partly around this question that Lord Willis raised, which is around nurses being able to work more towards the upper end of their scope of practice. So if NAs can take a less complex case, for example, somebody in their home who has fairly established care wound needs that the NA can go in and deal with quite efficiently and effectively, this frees up the registered nurse to spend more time with complex cases, which may require more of their knowledge and skill. So I think there's an issue about the distribution of cases, and indeed in that quote I gave and you implied, the capacity also of nurses to be able to spend simply more time with patients at the bedside. That quote from I think it was an NA or somebody saying that the Band 6 nurse had time now to spend more time talking to patients, getting a closer sense of bonding with them. So I think there are issues around the distribution of cases, time spent at the bedside and with patients, which nurses can now do. But as I say, I'm sure there are people in the audience who've got more examples of how the NA frees up the registered nurse if they want to come in with any of that.
Great, thanks, Ian. And just that question on the impact of apprenticeships and registered nurses, and indeed the change to nursing associates of the use of the apprenticeship levy. I realise that sometimes understanding what's happening around apprenticeships makes Brexit look easy, but just to try and answer quite quickly what you think the apprenticeship investment of money, but also the status and role and legacy of apprenticeship models is going to bring to this area in the future.
Well, I mean, obviously, from wave 3 on, obviously, we were into the apprenticeship model, as people will know. And this then obviously raises broader issues about how organisations use their apprenticeship levy. I mean, we found, I'm not sure if it was from the director's survey or other work, that the most common apprenticeship now in trusts is the nursing associate apprenticeship. And clearly trusts are drawing down from their levy pot to fund that. And I think there's additional money going into that now. It does raise broader issues around how that affects the training of others, for example. So if a considerable proportion of the training levy is being spent on NAs, what knock-on impact does that have on the training of other groups of staff? But clearly, the apprenticeship is the route now which is being used. I mean, I think I did calculate at one point using the number of expected TNAs and NAs and multiply that by the upper limit of the funding band for NAs. And I think it came out that the figure of £200 million was being taken out of the NHS by the apprenticeship levy. And if you multiplied the number of NAs and TNAs expected, which are around 15,000 by the upper limit of the funding amount for apprenticeship, it came to 100 million. So we're looking at the TNA and NA role taking around about half of the levy. So it is a significant spend, but the money is there in the apprenticeship levy. Did you want me to say more on the apprenticeship?
Well, let's ask anybody on the call if they would like to add anything more about either of those two questions, the one about apprenticeship levy and also apprenticeship roles, and also about the freeing up from what. Peter Griffiths, I don't want to put you on the spot, but you were asking some questions, or having a debate, and not having a debate, just having some chat with people about the freeing up from what. Is there anything you would like to add?
Yeah, sorry, I'm just trying to switch myself on.
Thank you.
Yeah, okay. Yeah, well, I think it's the fascinating complexity here, because of course what we're doing is, on one hand, putting people with additional skills into the workforce, but the implication being that if we're moving one group into that space, we're then taking the registered nurses away from it, and yet we're not certain whether or not patients are actually getting benefit from having a registered nurse providing that care. So often we've focused on freeing up registered nurses to do something else, but actually we've not focused too much on what they're not doing. But also, I think, I was just sort of reflecting that I think one of the things that's quite instructive here, I'm often, by throwing in things from the epidemiological evidence, I'm often sort of seen as being in the anti-camp, and actually I'm not really. I just think it's really complicated, and what we do know is that knowledge and skills in the workforce benefits the clients. We know that's very clear. I think how it actually then plays out is very challenging, whether or not there's a net increase or a net decrease, whether or not we genuinely make the workforce more flexible by introducing new segments into it. It's nightmare to schedule. We saw that in the comments that Ian gave earlier about the sort of a nursing associate being forced into working in a healthcare assistant role because of the scheduling. I think that these issues of who is actually able to do the work, and there is a real danger that we actually simply become less flexible. But equally, the possibility is that we're getting a more trained, more skillful healthcare workforce, which is all to the good. Yeah. Sorry, that was a bit rambly, but I wasn't quite prepared.
That's fine, Peter. And I think one of the nice things about research is to research uncertainty, isn't it? If we knew the answer, we probably wouldn't research it. So, Ian, unless there's anything you want to comment on there, I'm going to move to some other questions.
Can I just come back to Peter? I agree with what he says there, in terms of the scope for debate about the impact of the new role. I do think we need to know a little bit more about the different models which are being used to integrate the NA role into establishment levels, partly touching on whether the NA role becomes a replacement for the registered nurse, whether it becomes a replacement for one of the or an HCA, whether it becomes additional staff member. I think what I'm picking up, and what we're keen to explore further going forward, is that there does seem to be an interest and take up of this role at scale by trust. And people may come back and challenge me on that, but the people I'm talking to are taking on significant sized cohorts of NAs and TNAs. They're not just recruiting one cohort and stopping, they're taking on cohorts every year. Now, I don't know, we need to know why they're doing that, but the very crude response is they do see some value in it, otherwise they wouldn't be taking it on. So there is an issue to be explored as to why it does seem to be being taken up at scale by quite a few trusts.
Great, thanks, Ian. I've got a hand being raised by Ralph, but I wanted to turn to Helga Pile, who has asked a question about continuing professional development. Helga, if you're able to demute and ask it yourself, that would be great. Is that possible? Yes, yeah. Hi.
That's right. Hi, thanks very much. Yeah, I was just Helga Powell from Unison. I was just thinking about your the kind of uncertainty around stepping stone versus a bridging role in its own right, and just thinking forward around for those who want to stay in nursing associate roles and not go on to training to be registered nurses, what we might see CPD and career development looking like, because another thing that you brought out was that the role is seen as very holistic. It's not specialized in the way that nursing is, but would we potentially see that starting to change once people have been in the role for a while and they're looking for ways to develop?
It's a good question. I don't know the answer. I would say that presumably, well, it is the case that NAs will have to revalidate in a number of years' time. So there will be a kind of built-in need for continuing professional development amongst NAs. I suppose your question is also touching on what that CPD will actually look like in substantive terms, which is an interesting question. I think one that we should be exploring. The implication what Helga is that maybe once they're in post, that their CPD is rather narrowly focused rather than building on the generic type of approach that they adopted in their initial training. Is that the concern there?
Yeah, I mean, I think there's a tendency, isn't there, certainly in healthcare, that development and progression equals specialisation and a narrowing. So I guess it'd be interesting to see whether it's possible to maintain that sort of holistic approach and find ways for people to take that forward.
And maybe also how trusts and other organisations begin to see a role for the NA role going forward in terms of its potentiality, and whether they develop training modules around the capacity they think that role now has. So it may be also linked to broader organisational approaches to the role within the context of the broader nursing workforce that may affect future CPD, I think.
Great. We've got a question. We've had several questions and threads and comments about primary care and sometimes general practice, but we've now got on our chat room somebody who's saying that they're just in the process of establishing NA apprentices in primary care in our locality. And the first few started in October, which must have been interesting for them. It's Sarah Redhead. Sarah, would you like to just explain where you are and what's happening? Or shall we just read you on the chat? If Sarah's there, that would be great to hear from you directly.
Hello, can you hear me?
Yes, indeed. Yes. So
hi.
We're just reading your chat. We're not sure where you are, so perhaps say where you were. That would be great, and also how it's going for you and what your role is in this.
Yeah, so I'm working at Bucks Healthcare Trust with the Bucks Training Hub. So I've recently started out in post there, so it's a steep learning curve for me anyway. But we've got some just a few that have started from primary care in October as part of a wider cohort that are out from secondary care. So we're just doing lots of liaising back and forth with the uni and things, but there's obviously questions cropping up with regard to practice, such as smear tests, baby immunisations, that haven't really cropped up before within a secondary care concept. So we haven't even we've got close links with Bucks Healthcare, but a lot of the questions we can't really answer. So it's just, there's quite a lot of confusion around it, and obviously the guidance it's not definitive, because I suppose there are so many different areas within healthcare that guidance can't possibly cover all of that. And then also just logistics with placements and protected learning time and things that obviously the NMC have now got their own guidance with regard to, but how that's being interpreted is potentially not standardized across the board, if that makes sense. So we're finding some students are thinking that this protected learning time is different to what we would interpret it as meaning. So just if people have got experience with that already, that have already potentially set this up or had cohorts going through that are in their second year, is there anyone that we can kind of link up to just to sort of share resources and their experiences, really?
Great. Well, we've got an offer, Sarah, from somebody who is a TNA in a general practice, but more broadly, if people want to just send an email back to Jess, giving their permission for you to contact them, we can do that as a sort of broker system, or a dating agency, if that would sound good. Let's hear from Kirsty, who may be able to help that. Kirsty, you're probably not in Bucks or Buckinghamshire, but somewhere else. So Kirsty, if Kirsty Jenkins, if you're able to talk, that would be great.
Hello.
Hi.
Hi. So I'm a TNA in North Lincolnshire, working in GP practice at the moment. So I'm in my first year. So I'm happy if anybody wants to liaise with me, if you want my email address to send back to anybody. So the TNA role, I'm the first one in GP practice in our area to do it. So I'm a bit of a pilot scheme, if you'd like to say. So we've been looking at what roles we can and can't do with regards to baby IMS, which would be under a PGD, so we can't do that. But there are many other immunisations that we could do working under a PSD, like your Prostaps, your Zoladex and things like that. We're also looking at doing women's health, and as far as I'm aware in our area, once you've been qualified for a year as a TNA, you can go on to do your cytology training. What else have we been doing? Because of the change in our area at the minute, we're not able to go out on placement. So I'm having to do my spoke placement in my hub. So I've been working with the dispensary team, learning about medication, MHRA, and your yellow card reporting about controlled drugs and different things like that. So that's been quite beneficial, because that's something in my role as a healthcare assistant that I would never have done. I mean, is there anything specific people would like to know what it is a TNA in general practice could do? Because I think the role is evolving, and it's something that with the university where I'm at Hull University, we're looking to have some documentation for each specific area. So for acute, social care, general practice, where we're going to put something all together to give a bit of direction of what you can and can't do as an NA or a TNA in those roles.
Right. Well, thanks, Kirsty. That's really interesting, and we can understand how difficult it is for you at the current time, because I think rates are really high in North Lincolnshire, aren't they, of COVID? So it's good that you're able to do some sort of placement, even if it's in your hub. Rather than put Kirsty on the spot, if anybody's got any questions, perhaps put them in the chat first. We can move to some other questions, but please, anybody who's not put anything in the chat, we can try and see if the raising the hand works. That would be helpful. If not, we'll plug on with some of the questions there. There've been questions of how people are resolving things, like talking about getting hold of the partnerships to resolve some uncertainties, and a whole range of uncertainties have been discussed. But one that's come up a little while ago in a number of angles has been that issue of safe staffing, which I think is really important, obviously, to patients and care users and carers and everything. Ian, did you want to say a little bit more about that notion of safe staffing and how that's coming through in the evaluation, or how the whole debate about safe staffing is developing as far as you're understanding it?
Well, it's tied up to some extent with the skill mix issue as well, and there was clearly quite a lot of debate at the outset, not least within the context of a number of documents, some of which I put up at the beginning, which talked quite a bit about a skill mix. And I mean, the people on this webinar will know more than me some of the issues that are taken into account. I mean, the whole importance of quality assurance when it comes to the introduction of an NA role, and looking at the impact the NA role might have on care quality. And there was advice from a number of different sources stressing the importance of quality assurance. There are a number, obviously, of tools that people will all know about in terms of skill mix, taking into account the acuity of the patient. And there's a huge debate about safe staffing. I mean, my sense, and maybe it was very much an issue that was emerging and being discussed. I mean, and that given that we only did 2 cases, it's not an issue we explored hugely in the survey, and maybe we should do in greater depth. But I mean, I haven't got a huge amount to say on safe staffing, other than it was clearly tied up with the skill mix debate and how the role was being introduced within teams.
Right. So that's something to pick up later. Yes. We've got a question about education from Colin, who's not able to not able to put it in the chat, but that's great, Colin. We're very pleased to hear from you. I'm not quite sure where you are, so if you wanted to introduce yourself and raise some of the education points you wanted to mention, that would be great. And there's quite a lot of people in the chat saying, thank you very much, Kirsty. It was really great to hear from you. And indeed, we've got another nursing associate who might be willing to talk, who's working in a very different ITU context. So perhaps we could turn to Thea later on. But over to you, Colin, for some education questions.
Can you hear me?
Yes, indeed.
Yeah, okay. So I'm Colin Johnson, Senior Lecturer at Canterbury Christ Church University. And I've been involved with the trainee nursing associate program for about a year now. And I have to say I've had a very good experience of it. So I just wanted to say something from my experience, not only with the NA programs, but also the AP programs and the foundation degrees before that. And I see that as a kind of natural progression. So what I'm seeing is, what I know from having talked to students in the past, is that programs like this are a good avenue for healthcare employment as a healthcare employment pathway. So for those people that work in the healthcare field, that have some kind of an aspiration and want to develop their career. The other thing that I see with my experience is that amongst the healthcare assistant population, there's a vast sea of talent that's there anyway. And when they get onto a program like nursing associates, the educational component helps enhance their practice. So we just build the theory on top of what they know already, and they're just great at doing that, and we see some marvelous results. So it has been mentioned before that the nursing associate may not want to go on to an RN role, but I think the two can work side by side. But we need something like this to be able to motivate those who want to be able to progress in some way. And I think it's one way of valuing all members of our workforce at whatever level they work in. And to be honest, I've seen some fantastic levels of potential and actual leadership within foundation degree graduates, assistant practitioners, and the nursing associates that are coming through. Finally, I would just like to say that it is the linking of the theory and the practice, that relationship, again, that enhances patient care and patient care outcomes. And just finally, just to say, no matter whether you are a nursing assistant, assistant practitioner, nursing associate, a registered nurse, or the matron, we all have our scope of practice in what we can and can't do. So we should be limited by those kind of arguments. That's it.
Great, thank you, Colin. Some very interesting points there. We'll pick up on some of them, but I want to take a moment just to talk to some more nursing associates, if I may, in case they need to dash off. First of all, there was Thea, who was telling us just briefly in the chat that she's got an ITU role, which is, of course, very different from the work in general practice. Thea, is there anything you would like to comment on in this debate? You were telling people that how specialised that was by comparison. Are you there, Thea? Maybe not. If not, should we just move on to, was it Kelly who was also talking about from a nursing associate? No, Kelly, yes, talking about it from a nursing associate point of view.
Yeah, hello.
Hi, Kelly.
We work in community nursing, and we've just recently qualified the last couple of months as nursing associates, and we feel that not everyone is aware of this new role and what we're supposed to be doing. So there's a bit of confusion there. You know, we feel at the moment we're not doing anything that associate practitioner is doing. We're not doing anything different. Even some band threes, you know, we still feel as if we're part of that section, if you know what I mean. We still feel we're part of that, even though we've just finished a 2-year degree. You know, we don't feel like there's any difference.
Right. Let's ask Ian to comment on that. He was talking, I think, about whether the organisation was ready for nursing associates, but also that point about perhaps people feeling that their role is very similar to an AP role, Ian. What would you say to Kelly and maybe other people on this point?
Well, notionally, although I'm not sure it'll be any consolation to Kelly, the AP role has always been a much more bespoke niche type role, which has fitted in to particular clinical areas. So in a way, it was designed with specific clinical areas in mind, and the training very much developed in that way, whereas the kind of nursing associate role is more generic, providing a broader grounding in nursing, which may contribute to the fact that it hasn't always as easily fitted in to particular areas than the AP role. So I think there may be some kind of legacy issues about the difference between the AP role and the NIHR role in that respect. I think Kelly's point also relates to what I was hinting at in my presentation, which is that there isn't in any organisation an initial degree of uncertainty about how the role fits in and how it can be used, and that has to be worked through right the way down from the organisational level, but also within the team as well, and working through at team level what you can contribute at that level. And it's disappointing that it hasn't been considered earlier in a way in the process, because obviously you've been 2 years in training. So there's been obviously a significant lead time in developing how you might contribute. But clearly this is a process that needs to be set in train. Otherwise all your training will have gone to waste. And I can hear the frustration in your voice as well, in terms of you not being able to use the skills and capabilities that you've developed. And it's a bit of a shame really that you haven't found a place yet within the team.
And I think it's always difficult being the ambassadors or the vanguards of a new development, and you're facing that at the moment. We've got another nursing associate, Thea, who's had a little bit internet problems, but is now able to comment as somebody who's working in a very different role, Thea, I think, as a nursing associate. How's it been for you, and where are you?
Hello, can you hear me now?
Yes, indeed.
Oh, thank you, great. So I'm a first/second year trainee nursing associate at Oxford University Hospital Trust, and I work in the adult intensive care unit. And I just, sorry, this is going back to a point quite a while ago now, but during the pandemic, what the university trust, like one of the ways that they tackled the issue with staffing in ITU, that we had a nurse 1 and nurse 2 role. So the nurse 1 was the ICU trained role, and the nurse 2 was a registered nurse often, but from a different area of the hospital. And the research that's coming back from that now is that the ITUs are wanting to move away from, or are thinking about moving away from, the traditional one-to-one nursing style, and that they're looking to employ RNAs as part of that. So as opposed to the normal way of working, which is you have one registered nurse for a level 3, so very critically ill patient, or possibly one registered nurse for 2 level 2 patients, so a little bit less ill. They're now looking at having a combination of a registered nurse, or maybe 2, and then more registered nursing associates to work as more of a team. And I thought that's really interesting because there's been quite a lot of pushback, especially in ITU, because it's an area where nurses are very, very, very specialised. But we've got 2 registered nursing associates in our unit, and what they've done to equip those nursing associates with the ICU skills is that they've enrolled them into the foundation course, the year-long foundation course that the nurses go on. So they do get those specialist skills, and although at the end of that they are still a registered nursing associate and the nurses are still the nurses, that specialist ITU knowledge is exactly the same as the nurses.
Oh, well, that's very interesting, Thea, and takes the point about how valuable it is for researchers to do case studies, isn't it? You've described a case study that we would probably never find out from a survey or anything like that. So that's very interesting. And I think another bit that came up from the chat was probably the greater interest from learning disability services in NA work as well. And we'll take that up probably in case studies if we can do. We've got a little bit of the chat, and I know time is getting on now, that has been made reference to what Health Education England might or might not be doing and thinking. And we are lucky that we've got James here from Health Education England. And I wondered, without placing you on the spot, James, if there was anything you wanted to add to some of the discussions and the presentation that's been going on. So if you could just introduce yourself, James, and to anybody who doesn't know you, that would be great.
That's great. Thank you very much, Jill. So I'm James McLean. I'm the Deputy Chief Nurse for Health Education England, and I've got SRO responsibilities for all things nursing associate. So that's the trainees right through to the NA to RM pipeline. So looking through quite a lot of the chat, there are some stuff that we can actually help out with quite widely. We've developed quite a strong nursing associate ambassador program, and if you get in touch with your regional nursing associate leads, we can put you in touch with them, and they can go through quite a lot of the conversation pieces that are happening around the evolution of their role. And I think that's a really quite an important point that both Kirsty and Thea have alluded to, is that, you know, this is the newest nursing part of the family, and the roles will evolve as we gather more information about the levels of practice that they are pertaining to. We are nervous as HE that this is seen as just a bouncing stepping stone to the registered nurse profile, when actually there is a right for this role in its entirety, and Lord Willis alluded to that in his very first comments. And this is a standalone role within the nursing family. It's great that we've got at least 40% of our nursing associates that enter training into nursing associates wanting to move into a registered profession as a registered nurse. It is a regulated profession, and I think that's where we get some of the assurances and benefits that are associated with that. The NMC have been really on the ball with this from day one. It is, as I say, a regulated part of the profession. So the assurances that Ian's alluded to with revalidation and the continuing education of nursing associates if they choose to stay in that role, and we would hope that several do choose to stay in that role, because it is highly complex, it is highly supportive, and it will take time to to gather absolute traction. We need critical mass to be able to absolutely support the entire workforce in moving into the new world. But CPD will continue with the nursing associates. It's great to hear Thea and talking around the intensive care ask of this, and it is really a growing area of importance, and we've seen that through wave 1 of COVID, and potentially we'll see that through wave 2 as we are entering the critical phases of that too. They are a great adjunct to our entire workforce. And that's something that we have to keep really at the forefront of the conversation, is that it is another part. We are working towards multi-professional care delivery. They've got great skills, and some of the stuff that we need to start to do now is recruit from that wider recruitment profile. So not just your healthcare support workers, but taking them from access to healthcare courses. We know that there are a number of professions that have gone through extended furlough and potentially will end up with redundancies. Just using the Healthcare Support Worker 2020 campaign that's being run by NHS we can see that there are a significant number of that profile with either a very good level of secondary education and or degree level education, and we need to be able to talent map and streamline these people to the appropriate career pathways. And it is a career pathway. We want to be able to see you join the NHS at any level, to be fair, but if you're looking at those that are in that non-qualified workforce, we want to be able to take you from a non-qualified role right through to potentially the next director of nursing. So the pathway is beginning to be identified in that space, and there's quite a lot around how do we extend that out into other areas of our care workforce, and that includes health and social care. And we all know the issues that are surrounding social care at the moment, and Wendy Layton's on the chat box and has been really championing nursing associates into social care as well. So, and again, it's a great pipeline activity of how do we improve and how do we offer assurances to our patient population that we're using considered education, and we are using people that are highly adaptable, but also highly skilled in that space.
Great, thanks very much, James. And there's some input from your colleague Molly talking about some local linkages in Wessex, and she's also given her email there. Other people in the chat have also referred to buddy programs, talking about the way COVID has interrupted some of the organisational preparedness and readiness and so on, and that's been very useful, and how the implementation pathway has been somewhat disrupted by the pandemic. I loved your phrase, James, the bouncing stepping stone. I think that's a very good phrase to think about in many ways, that bouncing stepping stones are going to be the potential for this type of task. I'm just looking to see if there's anybody got any questions direct questions that I may have missed. If you've got one and the chat has eaten them up in many ways, please raise your hand or speak out. Ian, is there anything you had wanted to pick up from those bits of the chat that you've been able to pick up on, or anybody else would like to comment on it? We've had that notice about buddying and mentoring and roadshows and leaflets for patients and staff, maybe attracting them to find a friend, help their family join this task. And James has clearly alluded to the people who are really worried about their employment now, both in respect to furlough, but being made redundant, or perhaps have been inspired by what's been happening recently and want a change of direction, and feel their moral compass is pointing to this bouncing stepping stone. I've got some new messages coming up, which I'll just try and read briefly. Yes, a request to share the leaflets. Is that possible from, is that Mark that's saying that he's got some leaflets that somebody is wanting to plagiarize? Mark, if you're happy with that, that would be super. And then Wendy from Skills for Care is saying that they haven't had a national campaign about introducing the role in social care to the public, but that sounds like one might be on the cards. Wendy, is there anything you would particularly like to add from a social care perspective? As I've said, our own research is going to try and do more in social care, but there was a little bit of hiatus owing to recent events. Wendy, are you able to speak? Yes, hi, Wendy.
Yes, thank you. Just that there have been nursing associates right from 2017 who have flown the banner in social care, but it's been very, very small pockets. And what we have to address, I think, in social care, and James will know because I do bang on about this an awful lot, is the infrastructure support for the introduction of the role into that wider workforce. I think that's an issue for everybody, the wider workforce, but within social care, it is around those the training and support opportunities. And when we have registered nurses working often in a lone capacity, it is more difficult to provide the right support for the trainee. However, where we have seen the role in particularly in nursing homes as a starting point, then the role has become embedded as a registrant and is starting to do that. We need a lot more to get that embedded across the sector. And there is a lot of interest in the sector. It's just very difficult for them to cross the line at the moment. And part of that is around the whole issues around social care funding, how things are commissioned. So there's a lot to be done in that sort of arena, really. But I'm definitely an advocate for the role, and I can see how it can work very well in social care, across social care, not just nursing homes.
Yes, and thanks, Wendy. And there was some early chat about whether or not this had potential to be developed in domiciliary or home care work. And I think that will be really interesting to see. It may be that our work in Devon will pick that up, as well as talking about the more general care homes. And of course, if it's in learning disabilities, then we've got supported living and that whole range of provision, which isn't necessarily buildings based as well. We've got some other questions coming in. I did want to raise the point about, which comes from the social care bit in particular, about how the nursing associate is offering some real education and training opportunities from people who've been disadvantaged by current education systems. And it may be we will take an equality lens, an equality and diversity lens to what's going on as well, because clearly this is very important for all parts of employment. Peter has said there might be an untapped potential of HCAs and others who are ready to step in the role in the short term, but maybe the current pent-up demand for routes to progression has been met one of these days. Ian, would you like to comment on that? Rebecca said the cynic in me suggests it will never happen. So let's see what Ian would like to say and begin to wind up, because it's coming up to midday. I'm sure everybody in need of refreshment, if not a loo break. Over to you, Ian, for some concluding comments, maybe.
Yeah, the specific and then the general. I mean, on Peter's point, it touches a little bit on what I was alluding to in terms of that trusts are thinking about and beginning to look at an external pool of recruits to the TNA position, rather than their more traditional reliance on established HCAs. So they are appreciating that maybe they are getting to the limits in some places of the pool of HCAs they can use for that role, and going beyond to the external labour market and to self-funders. But that does raise some interesting issues around the kind of people that come in. And as I said in my presentation, one of the features of the TNA and NA role is that it has been undertaken by people who are trusted and known by teams. So when you bring in new people into teams, into the TNA role, it raises a new set of questions about how they become assimilated and accepted by team members. On social care and Wendy, I mean, it would be nice to talk to Wendy at length at some point in the future about developments in social care. Great, thanks, Wendy. And as Jill said, our plan is to track the cohort of TNAs through in Devon and see how they do develop. I mean, when I raised my slide about the range of different actors involved in the NA role, I think in the case of social care, the local authority emerges as very important, and Devon County Council is playing a key role, partly in terms of funding. So although many of the small homes don't pay the apprenticeship levy because they don't hit the threshold where they need to pay that levy, they can draw down 95% to cover apprenticeship costs, but even the 5% of the cost that these small care homes have to meet is quite a significant burden. So in Devon, the council is actually putting together a kind of support package which helps smaller homes take up the role. So I think that the local authority role is crucial there. I mean, I'm not sure what I'm saying in terms of general comment, except that thank you to everybody for participating and for their comments. We will be taking this research forward in ways that I've hinted at, and may even be in contact with you. Jess has mentioned the possibility of getting in touch with her, and can I just kind of reiterate that and say that if anybody does want to tell their stories about what's happening around the NA role in their organisation, we'd be more than happy or keen to talk to you about what's happening. In the case of individual NAs, again, it'd be really nice to talk directly to you. So again, maybe if you can drop Jess an email, if you'd be happy and I would like to talk further about your own organisation's story or about your individual story as an NA. But other than that, I think people have probably heard enough from me this morning.
The chat has very usefully made points about the apprenticeship levy being used for more functional skills, the literacy, numeracy addresses, which often have curtailed people coming into more registered roles in both health and social care. I think people are starting to sign off and saying thank you. Of course, we'd like to say thank you to everybody, particularly Ian and Jess for helping this webinar go touch wood so smoothly. We will keep in touch with you by sending out the slides and then later on the recording. And if you would like to come back to us with volunteering to perhaps have a further conversation, that would be really helpful.